Hi, my name's Karen Dunn Lopez. I'm an associate professor at the University of Iowa College of Nursing, and I am director for the Center of Nursing Classification and Clinical Effectiveness. I'll be speaking today about developing decision support for nurses, putting your documentation to good use. Hi, my name's Karen Dunn Lopez. After the presentation, I hope you all will think just a little bit differently about the potential value of nursing documentation. At the Center for Nursing Classification and Clinical Effectiveness, we aim to make nurses' role visible in healthcare through expanding the adoption and analysis of nursing documentation data using the Nursing Interventions Classification, or NIC, and the Nursing Outcomes Classification, or NOC. At the Center for Nursing Classification. So these are the two terminology sets that have been developed at the University of Iowa over the last 25 to 30 years. We think of nursing interventions as any treatment based upon clinical judgment and knowledge that a nurse performs to enhance patient outcomes. And outcomes are an individual, caregiver, family, or community state behavior or perception that's measured along a continuum in response to nursing interventions. Some facts about our center are that NIC was created almost 30 years ago and NOC almost 25 years ago. The editors are currently working on their 8th and 7th edition. Each of the classification sets have over 500 terms and are meant to represent nursing care rather holistically. The editions are refined with continuous support from practicing nurses, and so we thank all of them for that. The terminologies of the classifications have been used in 5 different EHR vendors, including Epic and Cerner, that are the most widely used worldwide. They've been translated into multiple language for international comparisons, including Norwegian. They can be licensed through our publisher at Elsevier, or if people are interested in research or demonstration pilots, people can get in touch with me about that, or if they're interested in help refining the classification. So some of you here might be thinking, I don't understand why we should spend so much time documenting in standardized terminologies when what we're doing right now seems to be working just fine. And I can agree that electronic health records have been very useful for putting information in. It's pretty hard to get information out. It's hard to look for the information you want, but when you're particularly comparing across patients and patient groups and trying to learn more, getting information out of the electronic health record has proved really challenging. And in the United States, we have something called the Quadruple Aim for healthcare. And that's an effort for us to improve health outcomes across our population, to lower the very expensive cost of healthcare. And we also want to do this while improving the experience of both patients and staff. So I believe nursing documentation using classification systems can help us achieve this quadruple aim by making nurses' role in healthcare more visible, helping nurses make the evidence-based decisions they want to make, provide nurses with the knowledge about their unique practice outcomes. And so here's a workflow of how we kind of get this done. In the upper left corner, those are clinicians that are documenting at the end of the shift and doing handoff. When their documentation is based in a standardized classification, it can be readily stored and retrievable within an electronic health record data area. From there, the data can be requested and processed by data analytic teams, including visual analyzers, data miners, and statistician. But this expert team also needs the help of healthcare domain experts. And I hear this over and over again when I'm working with engineers and we're looking at output. They really can't interpret its meaning without a nurse or a physician or a pharmacist or a social worker that plays a role in delivering the care where that data was generated. But with this great team, you can discover knowledge about practice that might be previously unknown. And with that knowledge, you have the opportunity to create something that can influence practice. I'll be speaking today about clinical decision support, and that can be developed and tested in a lab with a representative group of users. And if it proves to be both usable, useful, and effective, it can be implemented into practice. So I want to use the definition by Teak about clinical decision support, slightly adapted for nurses. So it's providing nurses with computer-generated clinical knowledge and patient-related information, which is intelligently filtered and presented at appropriate times to enhance patient care. And that intelligent filtering is what I mean when I say that the analytic team, the domain expert, need to interpret it and present it in such a way where it can be readily communicated for accurate understanding. So I do this work with a team that I've been working with for over a decade at the University of Florida and the University of Iowa. And here's some of the things we know about clinical decision support for nurses based on a systematic type review I conducted. One is that clinical decision support is much more frequently implemented for medical decision-making than for nurses. There are far, far fewer evidence in the scholarly literature of work supporting nurse decision-making. But among the 28 articles we identified, we found no negative effects on nurse-targeted clinical decision support on processes of care, on usability, or on patient outcomes. And that's really very, very important because unlike our physician colleagues, a lot of the nursing clinical decision support is tested in a real-world clinical context. That's kind of frightening when you think that if a CDS message was interpreted inaccurately, patient harm could occur, or workflow could be tremendously challenged on the basis of the clinical decision support. So I am very concerned about having nursing decision support tested in real world. We also learned through this review that 36% of the clinical decision support for nurses focused on helping nurses make accurate nursing diagnosis. About a third focused on helping nurses adhere to guidelines or medication management. And about a quarter of them really focused on nurses' situation awareness. And I want to bring your attention to the group at Columbia that is doing work right now using machine learning on nursing data to understand when a patient is deteriorating. So I think in the future, we are going to be seeing increasing sophistication in the types of clinical decision support available for nurse decision-making. So we've done this work with a few preliminary studies, and our first one, we analyzed nursing documented data from 10 nursing units in 4 different hospitals across 2 years. And we use quantitative methods, including data mining and regression, to learn what we could, these hidden patterns in the data. And then our goal was to derive practice-based knowledge and best nursing care practices for patients specifically who were near end of life. so helping nurses through that difficult time for patients and families. Our second preliminary study was to take those nuggets of new knowledge and develop a clinical decision support prototype using more than one format. And we did this using qualitative user-centered design approach, which is really the gold standard for testing technology, where you test it with potential users in small groups of 5 or 6, you redesign, and then you test it again. And we did that with about 45 nurses in a computer lab. And we were very interested in how easy it was to use these decision support prototypes, whether they were visually appealing, and whether the nurses comprehended the intended meaning of the CDS message. And this is a look at what our prototype looked like. So on the left-hand side, you see a nursing plan of care in NANDA, NIC, and NOC. This patient had 3 nursing diagnoses. That is impaired gas exchange, death anxiety, and acute pain. For the outcomes, they had anxiety level, anxiety self-control, and pain level. And then the triangles show the nursing interventions that the nurse had added to the care plan. So things like music therapy, calming technique, spiritual support. In the middle here, you see little rectangles with squiggles. This would be more visible to you in real life, but these are actual graphs of the trends on the NOC outcomes. And yellow is meant to mean it's below expected rating, but it's either staying the same or trending upward. Green is achieving the expected rating, but red is below the expected rating and trending downward. So for this particular patient with this plan of care, the nurse would see a small red graph that if they clicked, they would learn more information to help inform their decision making. So this nurse would see the graph that shows the pain trend since admission and what it was projected to be based on the pattern over this last 24 hours. The information is interpreted in a narrative form, and a suggestion is made to the nurse. So this doesn't interrupt the nurse's workflow, but it does give them an idea of something new they can do to help reverse this trend that shows the patient is not going to meet their goal. So in our third preliminary study, after creating these and testing it, the usability and comprehension and visual appeal, we wanted to get a sense of whether these worked. Did they help nurses make better decisions? And so we did a pilot randomized control trial with 60 nurses, and this was done in an immersive environment called a cave that had computer screens wrapping around almost 360 degrees around the participant and arching a little bit overhead. We also had sounds of the hospital to make it as realistic as we could in this lab. The intervention group had 2 patient simulated scenarios, and they could receive up to 14 evidence-based suggestions. And the formats were text, text plus table, and text plus graph format. The control group had the same 2 patient scenarios, but they didn't get any suggestions. So they were left to their own to make decisions. And both groups had the same task. They needed to make decisions for their plan of care as they would if they were in clinical practice using NANDA for nursing diagnosis, NIC, and NOC. So in terms of statistical results, overall, all of the CDS groups had higher rates of evidence-based decision-making than the control group. But I want to point out that this was towards the end of our study and the sample was underpowered. So it still doesn't give us an idea of whether the findings were true. And so what we did was we proposed and were able to earn extra funding for an adequately powered randomized controlled trial. This time, our sample is 200, and this is a national sample. And we are collecting the data about the experimental task via Zoom. Now, we planned this before the pandemic, but it proved to be a very useful way to collect data during the pandemic. So we were a little lucky there. The task was the same as in the pilot study where they had patient scenarios. They were to pretend they were starting a new shift every time they hit submit. They had up to 14 alerts and they needed to make decisions around building this plan of care. So I do not have the results for that study. We still have about 15 people left to recruit. And the purpose of this talk was not to present those results, but I hope to present them to you next year. Beyond clinical decision support, I'm seeing some increasing sophistication in how standing nursing terminologies are analyzed from the electronic healthcare record. For a good bit of time, information extracted from the electronic health record was only used to describe care. And now with a review by Maciera and colleagues at the University of Florida, we're able to see that increasing sophistication in measuring association between the variables, predicting care, and then to evaluate changes and to measure cost. And in each of these categories, the greatest amount of research is done in NANDA, NIC, and NOC. And in addition to those opportunities, there are vast opportunities for using terminologies that extend beyond ability to demonstrate nursing effectiveness. I have a colleague, Natney Da Costa Ferreira Oberfrank, who is using nursing outcome classifications as ways for patients to measure and report their outcomes for chronic illness when they're being managed at home. I work with a team of computer scientists and physicians where we are merging nursing documentation and physician documentation to automatically generate a patient summary that reflects both professions. And these are just a snapshot of opportunities within the terminologies or classifications. So these are the takeaways I want you to have for today. Using standardized nursing classification provides quantitative data that can be used to improve nursing care, make it easier for nurses to use evidence in their practice, improve the likelihood of better patient outcomes, and expand nursing knowledge. And all of this at little to no extra workload for the nurses. As a usability scholar, that's very important to me, that we're not adding workload to nurses. Here are some selected references you may be interested from myself and my team. And I want to thank you again for the kind invitation to present to you here today. Please contact me via email if you would like to continue this conversation, or follow me on Twitter if you would like to follow the work of our center. Thank you. There are some selected references you may be interested from myself and my team. And I want to thank you again for the kind invitation to present to you here today. Please contact me via email if you would like to continue this conversation, or follow me on Twitter if you would like to follow the work of our center. Thank you.
Good morning. I'd like to thank the invitation of Professor Bent Christensen to a digital talk in the session on use of standardized nursing language for quality assurance and research. I'm very glad to present the work, Nursing Diagnosis in Extremely Elderly Patients, a Big Data Analysis, in the Norwegian Nurses Organization meeting. This study was developed using the database of Aline Nomura's PhD dissertation, advised by me, and co-advised by Professor Lisiane Pruinelli from the University of Minnesota, United States of America, reference in big data science. This slide shows where we are from. Here, Brazil, the south of Brazil, and Porto Alegre, that has about 1.5 million inhabitants and has a long coastline on the Guaíba Lake, popularly mentioned as a river too. Porto Alegre is the capital of the state of Rio Grande do Sul, which borders the countries Argentina and Uruguay. Aging has produced changes in the population profile of current societies, creating new challenges with direct consequences for the public health system. One of the major challenges in this context is the vulnerability of the elderly, requiring a differentiated approach to their health planning in favor of quality and care security. Being old exposes patients to various conditions, such as cerebrovascular disease, cancers, and falls, increasing the vulnerability population. Although pain is not part of aging process, many elderly people believe that pain is a normal event in aging, so it is not reported. Thus, unreported symptoms, problems, and comorbidities in this population make evaluation and treatment difficult to deal with. The use of electronic health systems and the standardization of nursing records are closely linked to the quality of care management, which may promote decision-making and patient safety, giving visibility to nursing as a scientific discipline. In addition to this, the increase of the availability and quality of clinical data in electronic health records provide an opportunity to better understand the potential risks and benefits of critical health issues. Thus, through innovative strategies, it's possible to make use of structured and unstructured data from electronic records in order to optimize and seek improvements in clinical practice. However, in the various scenarios, an enormous volume of heterogeneous data and information is observed, distributed in a complex and poorly structured way, presenting redundancy and duplicity of data, in addition to the absence of a robust way to keep up with changes over time. Thus, the constant flow of new data that accumulates presents new challenges, such as collecting and storing it in order to analyze and compare and make decisions based on the findings. Through the analysis of large database, big data, of EHR and information systems, it is possible to obtain a privileged panorama, trace patients' profiles through repositories of clinical data, and thus make informed and accurate decisions, providing the opportunity for interoperability between systems and assisting in policy development. The ability to establish a nursing diagnosis requires knowledge about the multifactorial nature of the event, as risk factors, that contribute to the outcome. Thus, identifying the most prevalent diagnosis in extremely elderly people contributes to the establishment of more accurate goals and interventions aimed at the quality of patient care. The objective of this study is to identify the nursing diagnosis prevalent in extremely elderly patients. This is a retrospective observational study with secondary use of data that uses data analysis to guide planning and mainly the decision-making process. The data used in the study belongs to a Brazilian public university hospital, which serves 60 specialties with about 850 beds before the COVID. Since the 1980s, the hospital has developed a computerized system that in 2009 provided the capability of technology for the implementation of the system to hospitals throughout Brazil. Here we can see the Hospital de Clínicas de Porto Alegre. And again, this institution has been accredited by Joint Commission International since 2013. Here you can see the hospital management application is AGHUSE system that is a software developed at the hospital and it allows the recording of administrative care and care support processes in an integrated manner with the aim of improving patient care, access to research, and management of the institution. A healthcare management software has a focus of the patient. It's important to highlight that the nursing care, the nurses used the nursing process at the hospital with five steps, and the nursing classifications used are NANDA International Nursing Diagnosis, Nursing Outcomes Classification, NOC, and Nursing Interventions Classification, NIC. And the theoretical framework of basic human needs proposed by Wanda de Aguiar Horta, that was a Brazilian nurse from São Paulo. She used the Maslow human needs and the HANA categorization in psychobiological, psychosocial, and psychospiritual. Here is an example of a part of the nursing process that we use. We implemented a full risk prediction scale developed by the nurse Isis Severo, that was my PhD student. and we substitute the scale, the Morse-Fall scale used before. In the nursing prescription, if the result of SAC scale present a high score, the system alerts and the nurse asking if she wants to open the risk for fall nursing diagnosis. The population was electronic records of 51,643 unique patients, referring to a number of hospitalizations in the 5-year period in the clinical and surgical units, then between July 2014 and June 2019. The study sample comprises of all records of patients aged 75 years or older extracted from this population. The identifying patient data was released by the institution. Then data collection was performed using queries specially built for this study in order to extract the data necessary to define and conduct further analysis. A database was built for subsequent management. Through the data mining technique using structured query language, it was extracted the sample, its characterization, and the prevalent nursing diagnosis. As a taxonomic reference, the institution uses nursing diagnosis from the International, as I mentioned before. And nurses record this diagnosis in the electronic health record. This project was approved by Institutional Ethics Committee. As results, the dissertation database was used. Then the sample consisted of 7,207 extremely elderly patients. The average age was 85.5 years, where 53% were female. As race, the elderly were classified as indigenous, Asians, Hispanic, Black, or Afro-American, and the majority was white, 92%. Regarding the degree of education, the elderly were categorized as mainly incomplete primary education, with 46%. For us, is the primary education is the first 5 years. and 19% complete primary education. Regarding hospitalization, the main reasons recorded were circulatory system disease with 26.6%, neoplasm with almost 18%, then digestive tract disease, genitourinary system disease, and respiratory system disease. After data extraction, it was identified that on average, each patient had 5.9 diagnoses, being the most prevalent risk of infection with 73%, risk for falls, acute pain, impaired tissue integrity, these 4 nursing diagnoses, more than 50% of these elderly have, and risk for perioperative positioning injury with 39%. As conclusion, this study identified the main diagnoses in the elderly population admitted to clinical and surgical inpatient units of a public university hospital. The results highlight the large number of nursing risk diagnoses listed, which show the constant concern about the vulnerability of this specific group. Electronic record combined with taxonomies provide a basis for analyzing large databases, making it possible to obtain a privileged scenario for informed and accurate decisions. As contributions and implications of this study, we point out that knowledge about the profile of the elderly and their prevalent nursing diagnosis can contribute to institutional guidelines in the search for a better evaluation and re-evaluation, treatment, and involvement of this vulnerable patient in the care plan. The research provides subsidies for the clinical practice with an overview of nursing diagnosis to improve the care and safety of the extremely elderly. Besides that, studies demonstrate an urgent need to explore and expand data science in health promotion, care, symptom management, and systems. Thus, the identification of nursing diagnosis from electronic health records may benefit the establishment or improvement of standards for future investigations. This study was financial in part by CAPES and the National Council for Scientific and Technological Development from Brazil. And I thank you. I would like to thank you again for the invitation and the opportunity to be here.
Så det er noe av det som vi kan bruke strukturerte data til når vi får det på plass. Så jeg vet ikke, det noen umiddelbare reaksjoner? Ja?
Ja, jeg tenker at du kaller det for strukturert data, men så snakker du også om big data. Og da er jeg sånn usikker på hva hun tenker. Altså skal vi ha en strukturert kartlegging, eller ser hun for seg at vi samler alle data inn i et SNOMED-system, og så skal generere det ut derfra? Så jeg synes det var litt sånn uklart hva forskjellen på strukturert data og når vi snakker om big data, hvor de henter seg fra.
Big data i denne sammenheng nok den databasen av pasientsensitive data som da strukturert fordi at de definert med en terminologi som gjør at du kan spørre direkte på en gitt sykepleierdiagnose og få dem ut. Men det må være personspesifikt for at du skal kunne få den koblingen som vi ute etter når vi skal snakke om beslutningsstøtte og så videre. Og så igjen når vi da snakker om å bruke kunstig, eller utvikle kunstig intelligens på bakgrunn av det her, så trenger du ikke personidentifiserte data, men du må ha masse data, sånn at du kan få korrekte prediksjoner. Så, og det der med hvordan vi skal lagre data, det jo også et juridisk spørsmål som en del av digitaliseringsprosessen som i ferd med å falle på plass i Norge nå. Ja, da skal jeg få takke dere for at dere har vært med og hørt på denne sesjonen. Vi skal ha workshop videre her i dag for de som jobber med utdanning av sykepleiere, og for de som jobber i utviklingssentrene for hjemmetjenester og sykehjem. Så vi kommer til å snakke om dokumentasjon i hele dag. Og til dere andre som ikke skal være med oss, så må jeg si tusen takk for at dere har vært og hørt på.